hopefully useful scene setting set of comments on integrated care from a CHF consumer perspective. So on that note, we will move into our speakers, and I'll introduce them. We've got four presentations, maybe 4 or 5, and they're all very different and incredibly insightful. So over to our first speaker, I'd like to now introduce Professor Rachelle Buchbinder from Monash University, who will be discussing hospital in the home.
Thank you very much. I'm just sharing my screen. Can you see that? Can you see my screen?
Yes.
Yep, great, thank you. Sorry. To move. So I'm going to talk about hospital in the home. This was introduced in 1994 to save costs while maintaining high quality patient care. It's generally staffed by a mix of nursing, medical and allied health. And according to a Victorian report, it's consistently affirmed as being safe and appropriate. And it's believed to be less expensive. In 2019, this is an article about the Health Minister's plan to shake up private health insurance by having a hospital in the home revolution, claiming it provides more choice, better outcomes, better efficiency, and it's explicitly linked to trying to curb spiralling private health insurance claims, premiums, sorry. But in fact, there's insufficient evidence based on published literature for either economic benefit or improved health outcomes, although the data suggests probably equivalent outcomes. And so this is a review from a Cochrane review from 2017, looking at various subgroups of patients. So post-elective surgery, it looks like there's moderate certainty evidence that it shortens hospital stay and slightly higher satisfaction by patients, no higher mortality or readmission, but it's really uncertain about whether it saves money. Similarly for stroke, it probably has similar mortality and readmission rates, probably reduces risk of living in an institution, probably shortens hospital stay, but again, unknown effects on costs. For COPD, again, unknown mortality, might reduce the readmission rates, unknown effects on costs. And for mixed medical conditions, mainly in older patients, it probably doesn't increase mortality. It probably does increase risk of hospital readmission. And this could be, if you look at the confidence intervals, it could be quite a large increase or it may be no increase. It might lower institutional living. It might slightly improve patient satisfaction. And across the trials, it could reduce hospital length of stay from anywhere from less than half a day to 20 days. But again, there is uncertain effects on its costs and whether it's actually cost saving or not. So that's what the evidence says, and I've been interested in the talks this morning with the local I guess efforts to do better. This is a study that was published in the Medical Journal of Australia last year, and it was just around when we were about to do a very similar study. So I just wanted to briefly show you this study. This study was based on 19 of 28 unidentified, so de-identified principal referral hospitals, meaning that they're very large, most have ICUs, EDs and cardiac and neurosurgical units. And they had to be members of the Health Roundtable. Probably no hospitals from WA or Tasmania are included in these 19. And bearing in mind that we know there are 693 acute or psychiatric public hospitals in Australia and 300 private hospitals, It's a small snapshot, but nevertheless, it did provide some useful information over this period from 2011 to 2017. And in particular, among those hospitals, they did show that there was a reduction in length of hospital stay by, you can see there on the right, went from 2.7 days to 0.7 days, but a much greater length of stay at hospital in the home. So I'm not sure how much it costs to have a hospital in the home, because people are going to individual doctors, individual houses. So I'm not sure whether it would be cost efficient or not. When you look at the types of admissions that are using hospital in the home, you can see here a range here. A lot of them are relating to infection, including cellulitis and infective endocarditis, cystic fibrosis, and then it's things like aftercare from joint transplants and implants, and also malignancy. And over time, over that period from 2011 to 2017, you can see in the blue that the numbers of hospital in the home admissions for the top 50 DRGs has increased. So what we're trying to do is, using the Independent Hospital Pricing Authority data, we're trying to also look at the uptake of early supported discharge in hospital in the home across all hospitals in Australia, using the data sets that you see here for both public and private hospitals. And for the 2017 and 18 year, we have patient characteristics. So we'll also be able to look at trends over time. And importantly, while we're doing this, is to try and estimate the potential for cost savings associated with increased use of this approach, using propensity scoring, and from the hospital perspective, but knowing that this is a consumer part of the day, it's important to note that it's probably going to underestimate the true costs and the costs that are placed on the patients and their carers. In terms of what's changed as a result of COVID, and unfortunately we'll only have data up to the end of 2018, but one of the things that we're interested in is trying to increase uptake of both hospital in the home and rehab in the home post-joint replacement at Cabrini Health, where I work. And it was interesting to note that prior to the COVID epidemic, over 50% of people having both knee and hip replacements went on to have inpatient rehabilitation. But as a result of COVID, this declined significantly, particularly among hip replacements, where the proportion went from 58% inpatient care to 26%, and also reduced for knees from 55 to 44%. What we've seen in the last year is that gradually these numbers are going up again, but they're still not at the pre-pandemic level. And we do have an HCF Research Foundation grant to do a trial to try and increase the proportion of people who go home for rehab. And at the same time, we're also going to try and see if we can increase hospital in the home for these patients as well. And this work's being done by Jason Wallace, pictured there. So that's all I have, and just a shameless promotion of our book, which is much more related to the first session on overdiagnosis and overtreatment. That's our new book. And my other little cartoon there is just to also remind us that waste in the healthcare system isn't just a cost issue and a poor care issue, but we're also using carbon that is wasted and is also ruining the planet. Thank you.
Thanks very much, Rachel. And yes, nice call out there on you know, the carbon footprint and climate change message there. Very welcome. Okay, well, we're turning next up to Professor John Carnan and Mr. Andrew Partington.